Hi guys, it's X. Welcome back to my channel. On today's video, I'm going to be talking about how I organize my day as a trauma NP, specifically on the trauma floors when I'm on that service, opposed to when I'm on the SICU. I'm going to be going over my brain, what I use it for, and then basically how I manage my day. But I'm going to do how I manage my day without any meetings, because every single day, depending if it's Monday through Thursday, we have different meetings to go to, so that every single day is going to be different. I also want to say, this is going to be a disclaimer, that I'm not on my own time as an NP at my facility, because I do have an attending and I am on their time. So it's not like where in my specific job I can just go see my patients and do whatever I want when I want because there is timing for everything. And then I'm gonna go over my brain. I will take pictures of it and try to insert it. And this basically is how I organize my day. This is how I do my assessment, how I chart, how I know what I need for each particular patient. So I will go over specifically this with you. All right, I just added some things, diagnosis history, and then the little lab values. So I use one sheet per patient. Every single nurse practitioner, I think just like a nurse, is gonna have their own way of doing things. And I use the same exact sheet when I am in my bedside ICU job. I have tailored this. I actually got this specific brain from a nurse when I worked trauma ICU. That's why there's a little body here so I can write in like the injuries. But I specifically have tailored this towards my NP job and made it so I can just easily underline these things. So when I'm on the trauma floor, our presentations to our attendings are not as detailed. So a lot of this stuff I will underline for my own knowledge, but it's not something that I'm actually presenting or need to know specifically in rounds. However, when I'm in the ICU, we actually do go over every single thing that's listed on here. So I do have to write in, and then I'm very detailed. I like have a lot of other coworkers who don't write everything down. I don't know if they are just really good at making mental notes, but I have to write it down. If I don't write it down, I feel like I missed it. And I don't like that feeling. That makes me feel very uncomfortable. And I am a little jealous of the other NPs who can just jot down what they feel like they need to know, or like the doctors who write little notes and they just know things. But to me, I feel like I will miss something. So I'd rather just be safe than sorry. So I will take pictures and hopefully insert them and we'll go over them. So basically, a typical day for me, our sign out is at 6 a.m. So I try to get to work between 5:15 to 5:30. I can't get there any earlier because I live very far and I'm already waking up at 3 a.m. So you guys probably already know that if you watch my videos. Typically I come in, pick my patients, write down whoever. I'll print my sheet of like my list of what patients we have. Then when the nurse practitioners who are there, probably are there already, I'll write their names next to what patients they have, just so in case I get a call for a patient, I know who to hand the phone to. And then I'll start looking things up. My priorities are things that I can look up on the computer versus my phone, because there are certain things like I's and O's, or vital sign trends that for some reason on the Epic app on the phone I cannot look at. However, I can see that on the computer. So those are definitely things that I look up first because I can't on my phone. After that, we get sign out. So I get sign out, I want to say 6 to 6:30. So basically the night intern will come in, we'll go over all the patients who were admitted overnight, and then we will go over kind of all the calls that they got for each patient if they had any. Then we go to our first meeting. So our first meeting happens every single day. It's either at 6:30 or 6:45, just depending on the day. And we kind of just talk about all the patients who came in overnight, who's going to the operating room, anybody that is of concern. So even though I only work trauma and ICU, I am the ACS team, so acute care surgery team. And so we have many different groups that meet with us. So like our vascular team is there, our I don't want to say GI, but like our general surgery team is there. So we have two different groups for that. And then trauma, of course, and then our ICU team. So there is this huge group of people and then subgroups between them. And between those groups, I only work ICU and trauma. So I see a ton of people a day, like coworkers. We have just so many. And so then after we go through all that, and I really like this meeting. I don't care who goes to the OR that day because it has nothing to do with me unless it's like my patient in ICU or something. But I love to see the scans. So like if a patient is going to the OR and they just have like a concerning scan or head CT, we do bring it up on our projector and we look at it together. And I really like that and appreciate that because then I learn myself how to read these scans better. So I really like that. And then after that, I either go back after this meeting is done. So sometimes it's done around 7:15. After that is done, I'll go see my patients. I'll prioritize, so there's 4 different floors, lots of different units. I'll prioritize basically going to the top, going to the bottom, because at the end, like usually at 8:30, we meet in our trauma bay with our case management social workers, and then we discuss like what the needs are for the day, like what is keeping people here. So we'll go through the whole list and say like what someone needs. So like let's say somebody is pending a discharge and they just need like a front row walker. I'll let case manager know. That way we can just get that and see if like insurance is going to cover it, or if they don't have insurance, if they can just like pick it up at CVS or something, or if we can just give them one for free. And then after that, we meet with our attending, we go to the top floor, and then we just kind of go through the entire list of patients. So our census, depending on the time of the year, is sometimes really high. Right now it is very low. So it just kind of depends. We literally see every single patient together as a group. My group is pretty huge. So we have the attending physician, 2 to 3 nurse practitioners, sometimes 4, and then 2 to 4 interns depending. And then sometimes we have medical students. So sometimes we'll have 2 to 3 medical students. So sometimes we can round with like up to 11 people, and it's crazy because it's just this big group of people. I try my best to listen in on other things, or like if there is an injury that I have never seen before and we are rounding on this patient, like I want to pop in my head and just like see it. Sometimes we'll take stitches out, we'll take chest tubes out during the rounds, but basically during rounds is when we come up with our actual plan of care of what we're doing for that patient, or what we're presenting to our attending is basically me going over my patient, telling them what my thoughts are, what I think the patient needs, if it's something that I feel like I can't handle on my own, which will probably be a whole other video. And then if the attending agrees with me or not, I would just place those orders. There are certain orders that I can just order myself, but there are other things that maybe like I just need approval for before I do, because ultimately at the end of the day, even though I'm caring for the patient, it is the attending's patient. Like they're the ultimate decision maker. So after this, I will go back to my office and start writing notes and ordering whatever I need to do. And then if there was a chest tube or stitches or staples that didn't come out during rounds that I need to go back and look at. And then I try my best to circle back after my notes before leaving, just to see the patients one more time if I have time, because I really appreciate that when I'm an ICU nurse, I have a doctor who does that. He comes 2 to 3 times to see how his patients are doing. I just really appreciate that. Okay, so then after that, I give sign out to the night intern, and then I go home. But I want to go over what my brain is and what I think about, and I guess kind of talk about like interventions or like things, why are these things like, not interventions, admissions. Like basically when you admit someone, it's easy as a nurse because you like just look at all your orders, but when you're not a nurse practitioner, it's a brand new admission and it is a blank slate. You have to make sure these things are ordered. So I just do a full head to toe assessment, and this is how I generate a plan of care and make sure that I don't miss anything. So let's go over it. All right, I typically put my patient's name here with their full code, their allergies, their height, their weight, whatever, the diagnosis, the history, and then labs here. So I will go over this individually. We can talk about it. And then a lot of this is tailored to ICU. However, I will go over some of the things anyway. These are my consults, this is my deposition, and then here's kind of where I write my notes. And then to do is like extra meds that didn't fit and like what I need to do for the day. Keep in mind, I do still use this brain for my ICU job as a nurse, bedside nurse. And I will make a separate video on that for the ICU nurses or the nurses students out there who want to see it. And I use this same exact sheet of paper for that, and I just use it in a different way. Okay, so let's go over neuro. If this is like a brand new patient in the ER bay, so not everywhere I think every hospital that I've worked at focuses either on GCS or A&O. I just do both because at my job, my ICU job as a bedside nurse, we go through A&O. We don't really use GCS, so I just added both of them. So when I'm assessing a patient, the doctors and my NP job are really hyper-focused on the Glasgow Coma Scale, whereas as a nurse, when I'm giving a report to another nurse, they want to know like what the patient is allergic to. This is Q1 hour, so this is for my neuro checks, like how many hours. So for me, if I have a TBI patient that I'm admitting, this is going to be very important on the acuity. So like if I have a brand new trauma patient who has a head injury, of course this is going to be Q1 hours. I have to remember to order Q1 hour neuro checks for the nurse. Or if neurosurgery doesn't feel that is appropriate, I could do Q2 or Q4. Pupils, so I use this both for my nursing assessment and for my NP assessment because I want to know how big my pupils are because I need to know if there is a change. So I just write them down. And then restraints, whether this patient is restrained or not. Why this is a big deal, so there are certain facilities that if I'm discharging a patient to, I can't have restraints for 24 hours. So that is something that I have to take into consideration. And just as a provider, I need to know if I have to renew them. That way the nurse doesn't call me. So sedation doesn't really pertain to me on the trauma floor. However, it does in the ICU. So I just want to know what sedation they're on, whether they're on propofol or Precedex or SED. And then here I have the different types of pain medications that we use. So in trauma, we do a multimodal pain control. So what that means is we target all different types of aspects of pain. So if some of this is for like the ventilator, and I'm sorry, I did say that this was more catered towards my ICU, even though I was just talking about being on specifically trauma. So patients in the trauma bay do get IV fentanyl, but this is more like my drip. This is LI is for lidocaine, DI is for Dilaudid. Then I have Tylenol, gabapentin, Robaxin, and then Oxys 5s and 10s. So at my ICU job, we actually don't use any of these. We do morphine or Dilaudid or Norco. So, but at my specific trauma job for NP, this is all the different drugs that we do. So I just underline what the patient has, and if I have to increase pain medicine or add an adjunct, we use Robaxin as a muscle relaxer, gabapentin for nerve pain, Tylenol around the clock, and then either Dilaudid or Oxys, it just depends. And then lidocaine patches, because I'm trauma, a C-spine is very important, whether they're a C-spine precautions, full spine precautions. This just makes it easier for me to highlight and circle. Okay, next is their cardiovascular, like are they sinus rhythm, what is their beat per minute, then what is the map, do I have any goals, what have they been trending, if I have an echo, what is the EF. There's other things that we look at, obviously, like whether there is regurg of any of the valves or stenosis. And then here I have medications, if they're on like metoprolol, Lipitor. So we use a lot of propranolol for TBI patients to prevent neurostorming. And so sometimes I'll either put that here or put that up here. And then some attendings, not all, are very anti like standing hydralazine or labetalol for a blood pressure less than like 140. That's usually something that I come across a lot because our TBI patients, we want them to be under 140 if they have like a head bleed. So because of that, like it just depends on my attendings. Some attendings do want me to have PRN, labetalol, and hydralazine already set with specific parameters, like don't give hydralazine if blood pressure or heart rate is greater than 100, or don't give don't give labetalol if heart rate is like less than 60. So it just depends on my attending, like who is on. I have 11 different surgeons that I work with, so it really just depends on them whether or not I have that added. Another thing in regards to cardiac medicine, it's very important to go over the patient's home medication, because a lot of times that I see, especially in the ICU, is that we won't necessarily start medication from home, and then the patient will end up going into rapid AFib, and it could have been prevented if we would have just put them on their home medication. But depending on the situation, sometimes depending on how sick the patient is, sometimes we can't put them on their home medication because it's like a blood pressure medication, or they come in hypotensive, and obviously you're not going to start beta blockers if somebody's hypotensive. So that is just something that you also have to, like, when you're in the ER admitting a patient, like really pay attention to, is going over home medication and like what the patient's on. Or like Synthroid is another one that's very important. You can be off Synthroid for a couple days without it affecting you, but you just... Okay, next we're gonna go over respiratory. So this is if they're on oxygen, what their respiratory rate is, if they're intubated, the SpO2, if they're intubated, where is this at? This is important to some of my attendings in case we have to re-intubate a patient. They wanna know like what the size and where it was. ABGs, if I have them like Q6 or PRN, and then if I have any like duonebs, mucomist, 3% saline, CPT, vent settings, if they're on a vent, like what's the rate, what's the type of setting, BiPAP, what my settings are, high flow, what my settings are, and then chest tube, whether I have a right, a left, how many millimeters did they have out. This stands for incentive spirometer. This is very important. I kid you not, my head will be ripped off if there is no, by some of these surgeons, if I don't have an incentive spirometer in the room, because it is so important to prevent pneumonia. We want the patients to be exercising their lungs, and in trauma, there are tons and tons and tons of rib fractures. So one thing about our service is if they are elderly and have more than 3 rib fractures, we actually put them in the ICU for 48 hours, because that's how long it'll take for like pulmonary contusions to blossom, and they're at high risk of intubation for those 48 hours. So we really want them to actually put them on a high flow as well for those 48 hours. It kind of can be annoying, especially as an ICU nurse, when you have like a walkie-talkie patient who's only there for rib fractures, and it's like they don't need to be in the ICU. But in the elderly, like, we really want to prevent that pneumonia. So that is one thing that our hospital does do. That is like our guidelines for the elderly with rib fractures. So we will downgrade them after those 48 hours, and if they can pull like over 1,000 in their incentive spirometer. I actually really enjoy when I walk around and see that patients are like using their IS. I just think it's the cutest thing when they're like compliant. But anyway, along with this, so this is also a guideline for me. This reminds me, so when I'm admitting a patient, I'll literally look through these little notes, because then I'll remember like, okay, these are the pain meds that I have to order. These are the blood pressure meds that I have to order, or, oh, okay, maybe this patient has COPD, like let me make sure that they have their inhalers or whatever from home. So this not only acts as my assessment, like this is something that I fill out not only when I'm reviewing a chart, but also like when I'm deciding what orders to write. And then when I'm assessing a patient in person, like I write it down. That way when I go and I start writing my note, I could be as accurate and thorough as possible. Okay, let's go back. Okay, so GI, I put the diet here, whether they're NPO or on tube feeding, if they are NG, OG, or this is a core track. So not every hospital has this. It's also like a Dobhoff. It's just a small bore feeding tube. And then like if it's in the NARS, where it's at. Bowel reg is very important, especially if you're giving all these opioids. So I have Senna, Dopalax, Miralax, Colace. PPI is also very important. So in trauma, so Pepsid, Protonix, nausea meds, so either Zofran or Compazine, the tube feeding, how many flushes, how many hours, if they have a Flexi-Seal. So the Flexi-Seal is actually for my nursing job, because I'm very big on Flexi-Seals. Like I really want to know how long that Flexi-Seal has been in there, especially if it's been in there for like 30 days. However, in my trauma job, working general surgery, it is a huge no for Flexi-Seals. They talk about bowel necrosis, and I have seen bowel necrosis, unfortunately, from a Flexi-Seal, and the patient needed a colostomy long-term because of it. The patient was paralyzed, but still, like, honestly, I feel like if I was paralyzed, I would just want a colostomy. I don't want anyone wiping my ass, to be honest, but like, that's just me. So yeah, they are very anti like Flexi-Seal, and I feel bad for the nurses, because sometimes when these patients are just going bowel movement after bowel movement, like one, it's hard on the nurses, and two, like it's causing skin breakdown for the patient. So it kind of sucks. Flexi-Seal is convenient, but I know better than to even ask my attending if we can put in a Flexi-Seal. All right, next is GU, so ins, outs, and then the total, whether they have a Foley, a PureWick, a PrimaFit. PrimaFit also like condom cath, whether you're seeing the urinal, they're anuric, if they're getting dialysis, like how many liters out. That's basically what I have in my GU. It's another thing that this hospital that I work for as an NP is very big on, and that is not having Foley catheters. I, as a nurse, personally love the Foley catheter. I love having an accurate INO, but I don't really like the PureWick. I think it's kind of gross, and I don't feel like it's really accurate, but or like condom caths just suck. I still, like, I know things have advanced, but nothing beats a Foley, man. I mean, I know it causes infection, but I just personally love having the Foley as a nurse. The PrimaFit or PrimoFit or PureWick, whatever condom cath you want to call it, they just suck. Like, I've seen many brands, I've used different brands, and I just don't like them, but it's better than an infection, right? So we try to get those out as early as possible. A lot of the times I don't know if it's just specifically trauma, because I feel like I've seen this more at this job than any others, but I start Flomax or doxycycline so many times, like in order to like wake these bladders back up from those Foleys, and it just doesn't make sense to me, because as an ICU nurse at my other job, I don't see that happening a lot. Like I don't get it, but anyway, it is something to consider. All right, let's move on to Heme-Onc. Sorry, I lied. Fluid and electrolytes is next. So fluid and electrolytes is basically like, what am I on, if I'm on LR, NS, and how much. Electrolytes are like anything that I need to replace. I do have that written up here. In the ICU, I would have this little crossbones for the ABG, but I don't right now. I didn't write it in because I'm working trauma tomorrow, so I don't need ABGs. Nobody's going to be on a vent. I'm not hoping nobody crumps. Heme. So this D12, 8, and 6, that is more for my NP job. So I've noticed that I think county hospitals are more liberal with their blood draws, especially our level 1 trauma centers, like how often they get them. So at this facility that I specifically work at as an NP, when a patient is very sick and they first come in the ICU, we do get Q6 hour labs, or if their sodiums are off, Q6 hour labs are normal. Sometimes we go to Q8, sometimes Q12, others daily. At my ICU job as a nurse, it's more daily labs, and then maybe once in a while sodiums, Q6, and then possibly like a PRN if we feel like they're bleeding. But I don't draw labs, to be honest, as an ICU nurse at my other conservative hospital like I do in my NP job. We just draw labs way more often, but they are expensive, and the hospital has been trying to crack down on how much we've been ordering, and like if they're very necessary. Obviously, like I love having labs and knowing what things are and having trends, but if it's cheaper to the patient and they really don't need it, then you just have to be cost effective, and it's something that you have to consider now that you're an NP and not a nurse. Okay, so next in my heme section, I have a duplex, heparin, and then Lovenox. So these are the 3 dosages of Lovenox that we use for DVT prophylaxis, and then if they got blood. So duplex, in the ICU, we do these on day 1, day 3, and day 10, I believe. And then heparin, so for trauma, we specifically love Lovenox, and we use BID dosing, and we use 30 if they're less than 60 kilograms. We use 40 if they're 60 to 100 kilograms, and then 50 if they're over 100 kilograms. Heparin, we reserve more for patients who are TBIs or like head bleeds or like maybe like spine issues where they might have like a hematoma around the spine or something. We just rather use heparin because we can reverse it a lot faster, easier. Or like let's say they rebleed, we can stop that. Blood, I have like if they got transfusions overnight. ID, so this VZMC is like kind of the more ones that we typically use. That's Vanco, Zosyn, that's M for Flagyl, the metronidazole or whatever, and then C for cephalosporin. So this kind of, I've like been trying to figure out how I'm going to change this because I use a lot of cefepime, Rosefin, and Ancef. So like this doesn't really help to just underline because I use 3 different ones. So a very big thing is like start and stopping. When we started it, when we stopped, we're very conservative with our antibiotics, and we want to make sure that we're not aiding in resistant bacterial infections. And then my Tmax, like what was their maximum temperature that day. Next is endocrine. This is a very big one for me. A1C, was it checked on admission? How often are the blood sugar Acu checks? Insulin sliding scale, like what scale are they on? Are they on a mild, which is like 0 to 5? It's for this facility. Moderate, which is like 0 to 10, or resistant, which is like 0 to 12. And then Lantus, if they're on Lantus. This hospital also uses a lot of MPH that I don't like, but basically how many units are they getting? Next is musculoskeletal, and then I just threw this in here, but I mean this doesn't really apply, but SEDs, PT, OT, and SLP. So we use these a lot. I use physical therapy, occupational therapy in almost every patient, and then speech language pathologist I don't just use for dysphagia or stuff like that. We actually use them a lot for cognitive remediation. So in trauma, if you have a traumatic brain injury or lost consciousness or have a concussion, we have a speech language pathologist come out and evaluate you and see if you need like extra work. Next is skin, whether they have injuries. And then here's my cute little man. I just like to write like if they have rib fractures, is it on the left, is it on the right, like do they have staples, or if they have a broken leg, like where is it? And then consults and dispo. So I do have to specifically in my notes state like who I consulted. So this just lets me write like if I consulted rheumatology, if they're like elderly and have a hip fracture, we want to evaluate for osteoporosis, so like we'll consult them. Whether they have a broken bone, we consulted ortho. If they have a head bleed, we consulted neurosurgery. And this also helps me with follow-up. So if I write down like who I consulted and I read their note and they're like, hey, have this patient follow up with us outpatient in so-and-so weeks, I have it written here so that way I know. One thing that I need to add to this is like their tertiary exams, because every new trauma patient has to get a tertiary exam. That means a second exam, head to toe exam, make sure we didn't miss any injuries. The reason why we can possibly miss injuries is because in the primary survey or secondary survey, like you might not notice things like swell after a few days, or when the patient starts waking up and like the adrenaline is out of the body, like they start having aches and pains that they didn't before. So us just going in and reviewing every single thing and making sure that we didn't miss any injuries, re-looking over the skin, having them move all their joints and stuff. It's just make sure that nothing was missed. And then disposition is basically like, what do I need to discharge this patient? So PT, OT will come and evaluate all of our traumas. They'll tell us what they recommend, whether they can go home, or if they recommend like an acute inpatient rehab, a skilled nursing facility, an LTAC, or like if they need a manual wheelchair, a cane, a walker. And that's basically what I'm going to consult case management or like social worker for, if they need funding for these items. And then the last thing that was on here was just my IV meds. I'll show you real quick. So sedation, so propofol, Versed, fentanyl, IV fluids if they were on oppressors, or like miscellaneous. So the miscellaneous could be like heparin drip, Protonix drip, octreotide, any other drip that is just miscellaneous. I just have it there. And then I just write little boxes with check marks if I notice things and make sure I cross them off. So my motto as an NP is like, do what's gonna make you sleep at night. And I have a lot of anxiety. I mean, I'm still relatively new. I will be 2 years as an NP. Actually, I just hit my 2-year licensing, but like working as an NP will be 2 years in August. And so I don't do it every single day. So I won't sleep at night if I feel like I failed a patient, or like I feel like I didn't do enough for a person, you know, or if I miss something, game over for me. I won't sleep for days. So I just try to be as accurate and like organized as possible. So like I said, this sheet, this brain, I'm jealous of the people who don't need to do this, but it helps me sleep at night. So not only do I use this to go over a patient's like chart and see what they're already on or see what they need, this helps me with my admission because it reminds me of things that I might need to order. It also helps me with my note. When I assess them, I write it down, like what I saw their pupils look like, what I saw, like how much oxygen, if I noticed an abrasion somewhere. Like I like to be as detailed and accurate as possible. And this is how I format my note, is by systems. And yeah, it just helps me tremendously when I'm writing my note to give the most accurate detail. And like people always say, like if you're one of doctors that I like precepted with told me, like if you're gonna go to court, you see hundreds of patients and it might be like 5 years later, how are you going to remember this specific patient? And I'm like, you're right. Usually like do remember my patients, but when you see so many people in a day, they all blur. So I just want to be as accurate as possible and like very detailed, and like I write everything to a T. I probably overchart. So if I like our template will pre-populate certain things like the labs and stuff, but like I want to know when I wrote this note, like what were my med settings this day? How did they change from day to day? What was the update from here to there? So I just find this very helpful, very useful. I think as an NP, you kind of have to do what works for you, and this just happens to work for me, and that is how I organize my day. Somebody did request that I name a few resources that I use. To be honest, I don't really, I've been working in trauma for a very long time. Obviously, I don't know everything, and you're gonna learn as you grow. But in terms of resources, I don't like use anything for my typical daily labs because I know them already. Like I know all my norms. I know all my out of norms because I've been a nurse 9 years or 8 years, and these are things that I look at every single day. So like I don't use any resources for those. Maybe the atypical labs that I don't really order those things. Like if rheumatology wants like a vitamin D level or like a vitamin B12, not rheumatology, but just in general, like a vitamin B12, I don't know those normal ranges. So I'll look them up real quick. I do have a book, I don't have it with me, but it is, I think Mosley's lab book, like a manual of all the labs that you can order. So I have that book, but I'm not gonna sit here and say like I look it up all the time because I don't, but I do have that book. I do have a drug guide, but I rarely use that. But as a nurse, I've like, because I precept a lot of students, I also want to be really very like well versed in my drugs. So I started putting that at my desk so like I can read, even if it's common, and like Levophed. I use Levophed every day. Like I already know what Levophed does, what the side effects are, but it's still good to like look at the little nursing interventions. There is also the little antibiotic book that I have in my bag, but to be honest, my pharmacist is like my best friend. I make best friends with the pharmacist all the time because if anyone knows, like I specifically believe you should trust the person who that is their specialty. Like if I have a patient who's not breathing well, who am I gonna ask? The RT. Why? Because that is their specialty. Yeah, they might not be a doctor or an NP or a PA, whatever, but that is what they do. This is what they went to school for. So if I have a question or feel like something that my care plan is not working, ask your RT. So the same thing with the pharmacy. If there is a question that I have, ask the pharmacist. You can go on Up to Date, you can go on Hippocrates or whatever type of thing that you use, but I specifically would rather go to the person who deals with this on a daily basis, and that is their specialty and that's what they went to school for. I also have this little book called The Pocket Nephrology that I bought when I was a NP student because I was working with a nephrologist. He suggested the book. I bought the book because I didn't want to pay for it because I was like, it was expensive and I was a student, but I didn't want him to think that I wasn't serious, and I bought it and I actually really liked that book, and I have used that in a couple of times with like hyponatremia, like what the different causes could be. There's so many different causes, so that book I've referenced sometimes. So anyway, thank you guys so much for joining me on this video. Sorry that it is a long one, but I hope you enjoyed it, and don't forget to like, comment, share, subscribe, and I'll see you on the next one. Bye.